Yeah, I'm Dr. Nabil Mikhail. I'm a nephrologist here in Pittsburgh, Pennsylvania, and we'll be talking today about the topic of acute and chronic renal failure. I'll try to divide that into two sections. The first part will be about acute renal failure, and the second part about chronic kidney disease, and then we'll wrap up at the end. So acute renal failure has been redefined recently over the past couple of years by multiple criteria we'll talk about a little bit, but really the new definition now is called acute kidney injury, or the new name is acute kidney injury. There is the rifle criteria. If you look back for years, there had not been a very clear way of, the literature really hasn't used specific criteria to define what constitutes acute renal failure. So the rifle criteria and the two others to follow define specifically what is defined as acute kidney injury. The first one is called rifle criteria, and as we can see here on the slide, it defines R is for risk, injury, failure, loss, and ESRD. Risk is 1.5% fold increase in serum creatinine, or decrease in estimated GFR by 25%, or decrease in urine output by 0.5 ml per kg per hour for 6 hours. The injury is twofold increase and decrease in GFR by 50%, and the urine output is further decreased to 0.3 ml per kg for 12 hours rather than 6. Failure is threefold increase with decrease of urine output by 75%, and it lasts for 24 hours. Loss of function is complete loss of function, needing renal replacement therapy for 4 weeks, and ESRD is defined as complete loss of function for more than 3 months, which is Medicare definition of end-stage renal disease. There is another set of criteria called the AKIN criteria, which is Acute Kidney Injury Network, and that defined acute kidney injury as abrupt, which defined of between in 48 hours, absolute increase in serum creatinine of more than 0.3. So if the creatinine goes from 1 to 1.3, that would really be defined above baseline. Percentage increase in serum creatinine of 50% above normal, or oliguria of 0.5 ml per kg for more than 6 hours. Another classification is the KDIGO, which is the kidney dialysis income global outcome, which is a group that really has worked on a lot of outcome data in renal disease. And that is defined by a similar way, increase in serum creatinine of 0.3 ml per deciliter within 48 hours, or increase in serum creatinine by more than 1.5 times, or decrease urine output. So in a large way, the three of them kind of similar in the way they define acute kidney injury. And many labs have adopted some of these formulas into their system. So when the serum creatinine is reported as 0.8 one day and then 1.2 the next day, it will flag in the system as possible AKI, which is actually very good, as we will discuss later, in defining patients at risk and anticipating that there has been a change in serum creatinine, even though that 0.8 and 1.2 might fall within normal limit, but at least alerts us that there may be something that is starting. The KDIGO guidelines also classified it into stage 1, stage 2, and stage 3. And in a similar way, AKI is classified. Stage 1 is 1.5 to 1.9 times baseline. And then stage 2 is 2 to 3 or 2.9 times baseline. And stage 3 is 3 times or more baseline. Or other criteria, serum creatinine of more than 4, decreased urine output, and so forth. The next thing we really, when we have somebody with acute kidney injury based on this criteria, the next thing really we ask ourselves is why? What's the etiology? And that has really not changed for many years, and it's always been classified into pre-renal, intrinsic renal disease, and post-renal or obstructive. The intrinsic is further subdivided into vascular, glomerular, and interstitial disease. The pre-renal azotemia is fairly common. We all see it. And really it's classified into 3 subclasses. Hypovolemia, which is true hypovolemia, diarrhea, insensible loss, excessive diuresis, or bleeding. The other one, which is more difficult to establish, is decreased effective circulating volume in an edematous state. Somebody who has heart failure, severe aortic stenosis, and what is becoming fairly common actually is cardiorenal syndrome caused by heart failure and renal failure. These patients constitute a really management challenge because they have total body salt and water excess or hypervolemia, but intravascularly the renal blood flow is decreased and they have hypovolemia, renal hypoperfusion, I should say. Similar in liver failure and hepatorenal syndrome, where you have excess sodium, total body sodium and water, so they are edematous, but intravascularly they behave like hypovolemic patients. The other entity, which really we'll talk about a little bit further because it's fairly common also, is impaired renal autoregulation. And that is really, for us to do that, we'll talk about intrarenal hemodynamics. And we see that in non-steroidal use, ACE inhibitor ARBs, and cyclosporin. So the causes of intrinsic acute kidney injury, which is really not prerenal or postrenal, the kidneys anatomically and physiologically are divided into vascular, glomerular, and interstitial, or tubular interstitial. And because of that, the diseases behave the same way. So if you have acute glomerulonephritis, whether it's nephritic or nephrotic, can lead to renal failure, and we'll elaborate on that a little bit. Vascular can be large vessel disease, renal infarct, renal thrombosis, or can be small vessel disease like vasculitis. Large vessel disease can also be malignant hypertension, and also HUS and TTP associated with microangiopathic hemolytic anemia. Another entity which is not uncommon, but really you have to think about it, is atherosclerotic disease. And that typically happens after an intervention that involves the aorta, coronary angiogram or aortogram of any kind. And that can lead to dislodging of cholesterol emboli that ends in the kidney and can lead to inflammatory response that can lead to progressive renal failure. The tubular interstitial, really, we have primarily ATN and acute interstitial nephritis. ATN is acute tubular necrosis, fairly common, especially in a hospitalized setting. And really three things have caused that: ischemia or hypoperfusion, sepsis and infection, so ischemic or hypoxic and septic, and nephrotoxin. And there's really a large number. This is kind of a small synopsis, but these are the more common ones of nephrotoxins. They can be exogenous, like IV contrast, aminoglycoside, cisplatin used for chemotherapy, amphotericin B, and IVIG or immunoglobulins. Or they can be endogenous, intravascular hemolysis, rhabdomyolysis, which is not too uncommon, myeloma, and some medications cause renal failure by causing intravascular crystal deposition in the tubules. Acyclovir comes to mind, and that is a widely used medication. Sulfurs can do that, and some of the HIV medications can do that. Oxalates, whether primary hyperoxaluria or can happen in the setting of ethylene glycol poisoning, and phosphate. And phosphate, really just have to remember that sodium phosphate is widely used, and it is present in fleet enemas, which are also widely used. So using that in somebody with underlying chronic kidney disease have to be used with caution. It really is contraindicated because of the risk of phosphate overload and acute kidney injury. Acute interstitial nephritis we'll talk about a little bit in a later slide. Post-renal or obstructive has, you really look at the renal, the anatomy from the kidney all the way to the urethra. So it can be urethral, either stricture or a stone. Can be at the level of the bladder, and the most common is obviously BPH, stone sitting at the bladder outlet, or bladder cancer. Not as common as BPH, but the equivalent in women can be cervical cancer, or occasionally in uterine prolapse if it's advanced. Sometimes can lead to kinking of the ureters by affecting the bladder. bilateral ureteric obstruction or a single kidney, whether it's transplant or a single functioning kidney, if one ureter gets obstructed, that can lead to renal failure. Typically, single ureteric obstruction will not lead to acute kidney injury because the other kidney is functioning, provided it's functioning normally. The other reason for obstruction would be retroperitoneal, and either that can be lymphadenopathy in cases of lymphoma, or there is an entity called the retroperitoneal fibrosis. That is an autoimmune disorder, typically will present with increased SID rate and slight fever and fatigue, and can lead to renal failure with bilateral, what typically actually tend to be mild hydronephrosis, and that responds to steroids fairly well. I'll show this slide, and there will be a couple similar ones, but really that opens the discussion for the intrarenal hemodynamic. And this is, I think, is very crucial for us to understand how medications work and how ACE inhibitors and non-steroidals and other medications affect kidney function. So in a normal perfusion state, we have blood flowing from the renal artery to the efferent arteriole, and then the glomerular capillary, and then goes out to the efferent arteriole back into the renal vein and the systemic circulation. And what comes out of the glomerular capillaries will lead to the GFR. So in a normal state, blood flows through the efferent arteriole, out of the efferent, and then GFR. So anything that the GFR is dependent on intrarenal blood pressure or intraglomerular pressure. And that primarily is affected by hydrostatic pressure and to a lesser extent by oncotic pressure. So if we want to increase GFR, we would increase intraglomerular pressure. If we want to decrease GFR, we decrease intraglomerular pressure. And we'll see how medications can affect one or the other that can lead to decreased GFR. One of the two entities I want to focus on a little bit is contrast-induced nephropathy. The reason is we see a lot of it, and it is to a large extent avoidable or can be dealt with in a way that would significantly decrease the chances or the severity of contrast nephropathy. It is a leading cause of acute kidney injury in hospitalized patients. With normal kidney function is very rare, less than 1% incidence. It usually happens with a rise of serum creatinine in 1 to 2 days. It peaks about 3 to 5 days, and then if it's going to resolve, it typically starts resolving or improving after that. Usually it's reversible unless there is a significant underlying chronic kidney disease, and many of these patients probably would have ended on dialysis anyway. The incidence can be as high as 10 to 20% based on the risk factors. So one of the crucial things we really need to know is identifying patients at risk and knowing who are the ones that are likely to get into trouble. Underlying chronic kidney disease is one of the most important one, and the higher the creatinine at the time of contrast administration, the more likely that they will get contrast nephropathy, or the higher the likelihood of contrast-induced nephropathy. Decompensated congestive heart failure because of decreased renal perfusion. Diabetics are at higher risk, especially the ones with proteinuria. So proteinuric diabetics are at higher risk. Multiple myeloma patients are at higher risk. Patients with volume depletion or hypovolemia, again because of renal hypoperfusion. Also, the amount of contrast is important, and whether it is hyperosmolar. As we'll see in a little bit, that hyperosmolarity is one of the factors. So older agents tend to be were hyperosmolar. Newer agents are more isoosmolar and safer for administration. The higher the volume of the contrast given, the higher the likelihood of developing clinically significant acute kidney injury. So how does it happen? It happens usually vasoconstriction and hypoxia in the outer medulla, and will lead to vasospasm in mediators such as endothelin and adenosine. Also can potentially, the contrast gradient itself can affect that. It also directly tubulotoxic and can probably, because especially the hyperosmolar ones, can lead to transient tubular obstruction. Because of the intrarenal hemodynamics, it looks like prerenal, so it will typically be associated with low urine sodium. when we talk about contrast-induced nephropathy, typically we are referring to iodinated IV contrast used with CT scans and coronary angiogram. The gadolinium is a whole different topic. I will not focus on it this time, but there are some animal studies that suggest that gadolinium used for MRIs or MRAs can be nephrotoxic. But really, it probably is not significant, and I don't think there are clinical significance as of now. The bigger concern when we talk about gadolinium is what we refer to as nephrogenic systemic sclerosis. That happens in patients who have decreased GFR. Primarily, the highest risk is when the GFR is less than 30 mL per minute, and certainly dialysis patients. The reason is accumulation of gadolinium because of lack of renal excretion that will be deposited in the soft tissues, subcutaneous tissues, and lead to a picture like systemic sclerosis and can be very debilitating if it happens. So that is the concern why we worry about giving gadolinium to patients with decreased kidney function after we had thought for years that it was fairly safe and it had replaced, to a large extent, giving IV contrast. It turns out that it has some other issues. So really, how do we prevent contrast-induced nephropathy? First thing is really we need to anticipate it, identify the patients at risk from the list we talked about a little bit earlier. The use of isoosmolar contrast, which really most of the agents now, is safer. Minimizing the amount is an important factor. If a large amount has to be given, and that often we see that in cases with coronary artery disease, a patient gets an angiogram, they need 3 or 4 stents. When that happens frequently, the strategy is to stage the procedure and maybe repeat it multiple times and do maybe 1 or 2 stents at a time just to limit the amount of contrast exposure every time they get it. Diuretics, mannitol, dopamine, natriuretic peptides have all been used, and they really have not been shown to work well. People have tried prophylactic dialysis or hemofiltration, and that really is not recommended routinely because of the benefit is small, and obviously it is an invasive procedure, so it's not routinely recommended by most people to do that on prophylactic basis. So really the main thing that really works, what really works is IV fluids. IV fluids have been shown over and over again to be the single thing that really improve or decrease the chances of contrast nephropathy. There have been 2 ways it's been used, either normal saline, and it is definitely better than half normal saline in some studies. And the typical way is 1 ml per kg per hour for 6 to 8 hours before and 6 to 8 hours after the procedure. There are studies showing sodium bicarb, and one of the earlier studies used 3 ml per kg for 1 hour before and for about 6 hours, 1 ml for 6 hours afterward. That can be used if somebody is going to get a contrast. You don't have 6 hours because you need to do it quickly, so you can give them a bolus for 1 hour and then follow afterward. Both can be used, and the reason for alkalization is it may decrease oxygen-free radical-related injury. So both can be used. Acetylcysteine or mucomist, there have been multiple studies for the past maybe 8 years or so. And they are conflicting. There is a lot of study design issues, which patients were chosen to be treated. So really it's not completely settled at this point. But aside from GI side effects, there is really minimal risk. Otherwise, we, for the most part, continue to use it. The 2012 KD guidelines recommend using it, but the American College of Cardiology do not recommend using that. So if we use it, we typically use 600 to 1,200 milligrams twice a day, starting before the procedure, total of 4 doses. And having used it on a lot of patients, the main side effect is the smell, the taste, and some GI upset. The other area I want to talk about is non-steroidals and AKI. In primary care and in every other setting, actually, non-steroidal use is very widespread and very common. Young people use it, but older people use it more often because typically of osteoarthritis and arthritic kind of pains. Really, there is no difference between non-selective or regular NSAIDs and the COX-2 inhibitors. So in terms of renal benefit, really there is no difference. For GI, the COX-2 are better, but in terms of the renal effect is really the same. How it works? It works by blocking the vasodilatory effect of prostaglandin on the afferent artery. We'll come back to the diagram we showed a little bit earlier, and that will eventually lead to decreased GFR. The risk factors for developing this are similar to contrast: volume depletion because of decreased afferent arterial blood flow already, and then the NSAIDs will further decrease that. The decreased effective circulatory volume, and the use of ACE inhibitor or concomitant use of ACE inhibitor and angiotensin receptor blockers, which will lead to afferent arterial vasodilatation by blocking angiotensin II. We'll come back with a slide to show that, but in essence, you're really, by giving an ACE inhibitor or ARB, you're preventing protective vasoconstriction in the efferent arteriole, and then ACE inhibitors will go and decrease blood flow through the efferent arteriole, and that will lead to significant decline of GFR. So here's the diagram, and what we see here is the decreased vasodilatory prostaglandin if we use NSAIDs. The protective mechanism for that in a normal situation would be to increase angiotensin II that lead to vasoconstriction in the efferent arteriole to minimize the decrease in GFR. So still GFR will decrease, but by vasoconstricting the efferent arteriole, you are going to decrease the chances, and subsequently the injury might be less. So that is a protective mechanism, that if you give an ACE inhibitor, that angiotensin II effect will be blocked, or an ARB will be blocked, so the efferent arteriole will stay dilated, and then that will further decrease GFR because of decreasing of intraglomerular pressure. Also, NSAIDs can cause allergic interstitial nephritis by depositing lymphocytic infiltrate. They also can cause minimal change and membranous. Less common is the chronic use over many years that can lead to what is described as analgesic nephropathy due to chronic interstitial nephritis, and because of the chronic vasoconstriction in the medulla, it can lead to papillary necrosis. But really the most common is the hemodynamically mediated effect caused by transient decrease in the afferent arterial pressure. So as you can see, NSAIDs, they are widely used. They can cause kidney disease by a variety of factors. Hemodynamic is one, interstitial nephritis is two, and they are unique in causing minimal change and membranous nephropathy related to medication, which is typically not the case with other causes of interstitial nephritis caused by medications. So most patients who have interstitial nephritis, for example, do not have a lot of proteinuria. If that patient develop interstitial nephritis and they develop minimal change or membranous, they can develop transient nephrotic range proteinuria, and when you do a renal biopsy, it shows more a picture of interstitial nephritis. So you always ask about the use of interstitial of NSAIDs when there is a new change in the renal function or increased urine protein. And what I found over the years is when you ask patients about that, you really have to specify specific names of over-the-counter medications. Most patients do not identify over-the-counter medications as drugs, and they usually refer to the list of prescribed medications they are given. So they typically say no, but when you go back and ask specifically whether you've taken naproxen or ibuprofen, sometimes it resurfaces as they have been taken it. This is, again, the same diagram to a large extent, showing that in the presence of increased angiotensin II, there is vasodilatory prostaglandin that will increase blood flow. That would try to maintain GFR. the effect of ACE inhibitors, again, and angiotensin receptor blockers. So they will work on the afferent arteriole, as we can see in the diagram, is vasodilated because of decreased angiotensin 2. So the protective mechanism would be to increase vasodilatory prostaglandin that will further increase blood flow in the afferent arteriole that minimizes GFR decrease. And in a later slide, we'll talk about how then they are useful, because the question really, if we follow this, to say, well, if ACE inhibitors and ARBs do that, why then do we use them? We'll talk about that in a second or in a later slide. The other thing that is not maybe fully recognized is the acute interstitial nephritis. A lot of people don't put that in the differential diagnosis of an acute kidney injury in a hospitalized patient. And that happens because of inflammatory infiltrate in renal interstitium, usually caused by drug, about 75% of the cases. Antibiotics are the most common offenders, in addition to NSAIDs. Penicillins can do it, cephalosporins, rifampin, all quinolones, but Cipro more commonly, and it's the most commonly used anyway, and all sulfas can do that. Diuretics can do it. Loop diuretics and thiazide will cause interstitial nephritis. So not everybody who is been on diuretics has perirenal azotemia if the picture does not fit a hypovolemic state. Allopurinol, commonly used drug for gout, and PPIs, proton pump inhibitors, very widely used. They are available over the counter, very safe for the most part, but if there is unexplained rise in serum creatinine, it can cause, we need to think about interstitial nephritis. Some systemic disorders can cause it. Lupus, Sjogren, and sarcoid are one of the three of the more common ones. Some infections, Legionella, streptococcal infection, leptospirosis, and viral infections, especially CMV and EBV, can cause this. There is an entity, it's called tubular interstitial nephritis with uveitis. It is probably autoimmune, it's not fully understood, but basically you have a new onset renal failure and uveitis. It's called TINU, and the treatment is usually steroids. Happen typically in young people, so those who are in family practice, you're seeing younger adolescents or young people come to you with new onset renal failure and red eyes and uveitis. You may want to think about this, typically treated with about 3 to 6 months of steroids, and it works. Just to make a point here is interstitial nephritis, especially related to drugs, is typically an allergic reaction. And it is an allergic reaction, but some patients will present with fever, rash, and new onset renal failure. But really, the triad of all of them is about 20% of the cases. Many patients will not have the whole picture, and some patients will present only with new onset renal failure. So it should be in our differential, otherwise we can easily miss it because of the lack of rash. It can happen during the treatment, so somebody can be on a cephalosporin or penicillin for a few days or weeks, and then suddenly develops. Like any other allergic reaction, can happen anytime during the exposure to the medication. Glomerular causes of acute kidney injury. The big ones really are the nephritic or acute glomerulonephritis. The key here when we're thinking about glomerular cause of acute kidney injury is the presence of proteinuria and microscopic hematuria. I put here a slide to what is a dysmorphic RBC. So you send the urine down to the lab, they report back RBCs and protein, +2 protein and 10 to 20 RBCs. And sometimes there can be YBCs. The RBCs, as we can see them here, are RBCs that really ran through the glomerular capillary, which is pretty small, so they get dysmorphic and they have these budding things. They sometimes call them Mickey Mouse RBCs because they can have 2 of these, so it looks like the head of Mickey Mouse. That happens in acute glomerulonephritis, post-infectious or IgA nephropathy. ANCA-associated vasculitis will cause a nephritic picture. Anti-GBM will cause it, and of course lupus, especially class 3 and class 4, that is focal and diffuse proliferative glomerulonephritis. Cryoglobulinemia typically will be associated with a rash, and most cases of cryo now are caused in patients who have hepatitis C. And there is an idiopathic form of RPGN, or rapidly progressive glomerulonephritis. So it really should be in your differential of unexplained renal failure, especially in the presence of microscopic hematuria and proteinuria. Nephrotic patients that usually is more than 3.5 grams a day, but do not have active sediment, don't have a lot of RBCs. It still can happen in some patients with IgA nephropathy and membranous. They can develop what we call superimposed crescentic glomerulonephritis. So you can have somebody who's had membranous nephropathy for years, and then they develop crescentic glomerulonephritis, which in essence, acute glomerulonephritis on top of nephrotic syndrome. Rarely in patients with minimal change, primarily because of very low serum albumin. And there is a form of FSGS, or focal segmental glomerulosclerosis, that's called collapsing FSGS in HIV patients. And that is usually, it progresses pretty quickly, sudden onset of massive proteinuria, 10, 20 grams a day sometimes, with rapid decline in kidney function. Non-steroidals, as I indicated earlier, can cause interstitial nephritis, but that looks nephrotic. And amyloids, in the presence of monoclonal gammopathy, also can be nephrotic and lead to progressive renal failure. So we went through the definition, diagnosis, causes. So when really a patient, whether comes into the hospital or you see in the office and they have new onset renal failure, what kind of workup you do? Obviously, that covers a lot of territory. So I'm just going to go through the initial workup of really where to start to kind of narrow down the differential diagnosis. So the history and physical remains very important, because a lot of this really is kind of detective work. You really need to think about what is the patient's been taking, what their conditions are like, to really try to narrow the differential. Otherwise, you have a very long list of potential causes of renal failure. So we look for clues for pre-renal azotemia or post-renal azotemia. Somebody has urinary symptoms, BPH obviously is a common cause. New onset rash makes you think about interstitial nephritis, vasculitis, or Hino-Schönlein purpura. If the patient has new onset pulmonary symptoms, whether it's hemoptysis or new onset asthma or sinus problems, you think about vasculitis and you think about anti-GBM, or what we call pulmonary renal syndrome. Diarrhea, rash, and CNS symptoms, usually this combination, and new onset renal failure. You think about microangiopathic hemolytic anemia, which is the HUS and TTP spectrum, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. The patient has hepatitis, you think about glomerulonephritis and cryoglobulinemia. If the patient has HIV, you think about FSGS or collapsing FSGS. Urine remains one of the most important things, actually, in a way, to narrow your differential diagnosis or guide you to the next step of investigation. So examining urine sediment is very important, but even just the urine analysis that comes to you from the lab, if you're reporting a lot of RBCs, protein, then you're thinking more about glomerular injury. If there is a lot of granular cast, what we call muddy brown cast, we see that in acute tubular necrosis of any kind. Fraction excretion of sodium and urine sodium remain helpful. Less than 1% FeNA suggests pre-renal azotemia. More than 1% suggests acute tubular injury because the tubules are not able to absorb sodium. Renal ultrasound has to be done in every case to rule out obstruction. Whether it is positive or negative, it is important to know. Again, if there is a lot of RBCs on microscopic hematuria and proteinuria, we would send serological studies, ANA, DNA, complements, ANCA studies, anti-GBM, that would really take us down the list of causes of glomerular causes of acute kidney injury. So management of acute kidney injury really is managing the underlying cause remains the most important because it's caused by something, so really need to treat that. Supportive care, volume correction, electrolyte management, and avoid hypertension, which whatever the cause, initial cause, it just will make it worse. And then specific treatment, we will not go into each one of them, obviously, but would include really immune suppression for immunologically mediated injuries. Steroids and cyclophosphamide or mycophenolate or rituximab for patients with lupus, vasculitis, RPGN, or interstitial nephritis. Just think about anti-GBM and hemolytic uremic syndrome or TTP. One of the important things to identify these things early is the main treatment plasma exchange and plasmapheresis, in addition to some immunosuppression. If there is progressive renal failure, despite of conservative management, then we think about renal replacement therapy. That can be intermittent hemodialysis, whether it's daily or 3 to 4 times a week, or continuous renal replacement therapy. And that can be either CVVH or CVVHD, that's continuous venous hemofiltration or continuous venous hemodiafiltration. Or SLED, which is slow, low-efficiency dialysis. The main reason to use this, usually in an ICU setting, is when patients are hemodynamically unstable, and especially if we want to remove volume. So when we do continuous modality, we are removing less volume per unit time that would allow the patient to tolerate it. So if we're going to remove 2.4 liters in 24 hours, that's 100 cc's per hour, as opposed to 2.5 liters in 4 hours, that would be 600 cc's per hour. So if somebody is hemodynamically not stable, will not tolerate it. There has been a lot of studies about how frequent, which modality, and how long. That remains not fully settled and remains a clinical diagnosis of when to start dialysis and when to stop it and how frequent you do it based on multiple other factors in the patient's case. The indication to start renal replacement therapy, volume overload, hyperkalemia, metabolic acidosis, only if they are not responding to conservative management. Uremic encephalopathy and uremic pericarditis are the ones that usually will force us to dialyze patients irrespective of their, whether we can manage, because really there is no conservative management otherwise. Some toxins are removed by dialysis. Lithium toxicity is one of them. If the level is more than 4 milliequivalents per liter, ethylene glycol, methanol, if there is end organ damage, or with the level mentioned here, is effective in removing the toxins while you're managing them conservatively as well. The second half, we'll talk about chronic kidney disease. And chronic kidney disease, really when we see somebody with elevated creatinine, basically we ask ourselves 3 questions. How long, to determine whether it's acute or chronic? Why, which is the etiology? And then really where do I proceed from here? What am I doing from here? Which is the workup and management. KDOQI, which is Kidney Dialysis Outcome Quality Initiative, have published really the chronic kidney disease definition as opposed to what we used to say as chronic renal insufficiency. So the definition is really 3 months. It has to be more than 3 months of structural or functional abnormality in a kidney, with or without GFR. So if somebody has microproteinuria or somebody has polycystic kidney disease, have normal creatinine and no decrease in GFR, they still have chronic kidney disease. And if they have, or if they have decreased GFR of less than 60 mL per minute. It is defined, as we have become familiar with, into stages 1 to 5. 1 is kidney damage, as I indicated, with an estimated GFR of more than 90. 2 is kidney damage between 60 and 90. And stage 3 is decreased GFR between 30 and 59. That's now recently been subclassified into A and B. A is 45 to 50 to 60, and B is 30 to 45. Stage 4 is severe decline in GFR between 50 and 29, and stage 5 is less than 15 with or without dialysis. Many patients have a GFR of 12, but they're not on dialysis yet. It will still be stage 5. So the causes and etiology and the screening, what do we really do with these patients? And I think that is a common situation that many primary care physicians will face. You have a patient come to your office, you see them, and month after month their creatinine is 1.7, 1.8. And really what is, I always get asked this, is what is the extent of the workup do I do? You can, there is a degree of appropriate workup. There are certain patients that are at risk, and these are the ones that you want to focus on a little bit. Diabetics, hypertensive, hyperlipidemic, smoking, patients with hepatitis C, HIV, or family history of polycystic kidney disease or other renal disease. The NKF, DOKI, and KDIGO both recommend screening these patients even without necessarily having symptoms of kidney disease. The other causes and the etiology are very similar to what we have talked about in the first half of this lecture, which is really the exception of the pre-renal, because pre-renal by definition is going to resolve quickly in somebody with chronic, with the correction of the volume. So really you're left with either post-obstructive that lasted too long, or all the other causes of chronic kidney disease, of glomerular or intrinsic kidney disease that we talked about a little earlier, and post-obstructive. So what are really the goals of therapy? What is the workup that we need to do? Really the goals of therapy is, first of all, identify if there is any reversible causes of kidney dysfunction. The second thing is to prevent or slow down, provided that really you cannot reverse the cause. How do we slow it down? The third thing is treatment of consequences or complications of chronic kidney disease. And lastly is identify the patients that are probably going to, in their lifetime, progress to develop end-stage renal disease that will require renal replacement therapy, and how to prepare for that. So one of the most important things we can do for patients is blood pressure control, irrespective of the underlying cause, whether they are diabetic, hypertensive, or other cause, post-infectious, post-glomerulonephritis, and they are left with significant degree of kidney disease. Then you want to focus on the blood pressure. The NK-DOKI guidelines recommend goals and also agents. For the most part, diabetics and proteinuric patients need and should be on an ACE inhibitor or angiotensin receptor blocker as a preferred agent. If you can, and if they don't have a contraindication like an allergy or angioedema, or they become severely hyperkalemic every time you put them on an ACE inhibitor. Other agents can be used on top of that, usually are beta blockers, calcium blockers, and diuretics. Diuretics are almost always in renal patients are needed, whether it's a thiazide diuretic or a loop diuretic, but most patients will need a diuretic for adequate control of blood pressure, just because the amount of sodium consumption. Diuretics are particularly important in African American because they tend to be more salt sensitive. Patients who are not diabetic, the goal still should be around 130/80, but we don't have to focus as much on an ACE and an ARB. But proteinuric patients for sure need to be on an ACE or an ARB. We'll talk about that in a little bit. So this is a slide from UpToDate, shows how ACE inhibitors and angiotensin receptor blockers work. We know that angiotensin 1 becomes angiotensin 2, and ACE inhibitors work on that level, and then angiotensin receptor blocker work on the 1 receptors. The difference between the two is the kinins changing to bradykinin with the ACE inhibitor, and that is why many or some patients develop cough with an ACE inhibitor, and these are the ones we switch to angiotensin receptor blocker, because the ARBs do not have that effect on the bradykinin. This is a similar slide, but really kind of talk about why do we really use ACE inhibitors in these patients. The clue here is really intrarenal hemodynamic. In somebody who has chronic kidney disease, especially diabetics, there is decrease in the nephron mass. So if you have a million glomeruli, you lose 25% of them, you have only 700,000 or 75% of them. The blood flow through the kidney, through these glomeruli, will lead to hyperfiltration, exposed to high pressure, And like any other blood vessels, when it's exposed to high pressure, eventually there will be endothelial hypertrophy, subsequently sclerosis, and will lead to gradual loss of further glomeruli independent of where the original injury started from. Proteinuria causes the same thing, and this theory is called hyperfiltration. Hyperfiltration is basically more blood flowing through less glomeruli that eventually lead to progressive glomerulosclerosis. ACE inhibitors, as we talked about before, will open the efferent arterioles, and by blocking the angiotensin II effect. So in essence, it will decrease interglomerular pressure, and by doing so, it will decrease GFR on the short term, but it will prevent the interglomerular hypertension year after year, and that will eventually lead to less decline in kidney function, and that's how the protective effect of ACE inhibitors and ARBs work. So on the short term, they might decrease it, but when it's been studied, especially in diabetics and other forms, patients who have been on ACE or ARB do better than patients who were not, and because of decreased progressive glomerulosclerosis. The trick is when this particular patient who has been stable on an ACE or an ARB with maintained creatinine of 2 because of the desired effect, when they develop an acute injury because of decreased renal blood flow or a non-steroidal like we showed earlier, these are the ones that will develop acute and chronic, and the creatinine will go from 2 up to 4 because of that short-term decline in their GFR caused by the other problems. How do we deal with this? We hold the ACE and ARB temporarily. We give them volume, remove the offending medication. GFR goes back to where it was before. They go back to their baseline. And then what we have to be careful of is not to abandon the use of ACE or ARB in these patients because of the underlying problem. So any patients who develop acute and chronic renal failure, we need to carefully think about why develop the renal failure. And then if ACE or ARB were one of the causes, at the time of discharge, we really need to re-examine what was the initial indication in the first place and whether it would be safe to put them back on this medication, particularly if they have a good indication. And that's mostly either cardiac cause for cardiomyopathy or proteinuric renal failure. If they have proteinuric renal failure or cardiomyopathy, by all means we should re-challenge them and be careful of the other causes and alert some of these patients to really, if you develop severe diarrhea, if you develop acute illness or fever, you need to let us know, but maybe during this period of time, we want to decrease or hold their ACE inhibitor or ARB. And that is a very common scenario we all face. So when one extreme, using ACE inhibitors and ARBs on everybody, especially patients at high risk that don't have an additional benefit from an ACE or ARB. On the other extreme, I see sometimes is abandoning or stopping ACE or ARB or anybody with high creatinine or anybody who develop an episode of acute renal failure. Both extremes, I think, are wrong. It's just a careful of analysis of why they're on it in the first place and what happened that caused the creatinine to go up, and then reevaluate the situation. So how do we manage further management of chronic kidney disease? Modest protein restriction have been shown to slow progression. However, we have to be careful in older patients that really that can be counterproductive if they've developed malnutrition. So on the balance, if we think there is a risk of malnutrition, we don't advise patients because otherwise the risk would outweigh the benefit. But if you have somebody who is eating a lot of high protein or one of these high protein diets, it should be discouraged for sure. Lipid-lowering agents are used usually for other reasons. There is some evidence, although not conclusive, that they might slow the progression, but the main reason to use a lipid-lowering agent is many of these patients have other risk factors. The other thing that chronic kidney disease by itself is an independent risk factor, equivalent actually to prior coronary disease. So they should be dealt with as patients with a significant risk. With the goals of LDL less than 70. Smoking cessation may slow progression because of decreased vascular disease, and then the use of ACE inhibitor or angiotensin receptor blocker, as we talked about, especially in proteinuric patients. Anybody above 500 milligrams should be put on an ACE or an ARB. The other things that we see in many of these patients is hypervolemia and volume overload. Not uncommon, and that's what I said earlier, is you need to have them on some form of a diuretic. As the GFR declines, usually loop diuretics are better and they are more effective. So many of these patients will need a loop diuretic. Hyperkalemia, typically mild, potassium of 5.2, 5.7, is not uncommon in many of these patients who have creatinine of 1.8 or 2. Many of these patients, especially diabetics, have type 4 RTA. We're not going to focus too much on that, but quickly this is hyporeninemic hypoaldosteronism, and especially in the presence of ACE inhibitor and ARB, it will accentuate the hyperkalemia possibility. These are the patients that will also get into trouble once we put them on a small dose of ACE or if we put them on aldactone for cardiac disease. We restrict potassium in the diet. We hand out to patients a lot of the diets that have high potassium. Most of these are fruits and vegetables. Dairy products have high potassium content. Avoid potassium supplements and be very careful of using a combination of ACE and ARB, or ACE and ARB combination is discouraged these days, but also ACE or ARB in addition to spironolactone or potassium supplements with the Lasix. Most patients who are ACE or ARB need a loop diuretic, and that should be enough. If you're going to add a potassium, you really have to check them very closely, and you have to demonstrate that they've had hypokalemia before you prophylactically put them on a potassium supplement. Multivitamins over the counter, many of them have some potassium, so we recommend that people don't use that. There are renal vitamins if the patients want to be on one. And then the use of loop diuretics. Metabolic acidosis is one of the other consequences of chronic kidney disease, and it can be either an ion gap because of accumulation of hydrogen ion because of lack of renal excretion. The other one, most of these patients have some degree of non-anion gap metabolic acidosis and renal tubular acidosis. Sodium bicarb supplementation may slow down the progression, but also very important that chronic metabolic acidosis, those who have a bicarb of 17 all the time, will use calcium and phosphate from the bone to buffer the blood, and that will lead to progressive bone loss. And also there is evidence that it will diminish albumin synthesis and will decrease to malnutrition. So most of these patients have to be put on sodium bicarb supplementation to keep their CO2 21 or above. Just a caution that sodium bicarb is sodium. So in essence, we're giving them sodium load. So you almost always have to use that in combination with a diuretic to decrease sodium retention while you're giving them bicarb. Hyperphosphatemia is another consequence. We see that. Just a reminder, phosphorus is not part of the BMP or CMP that is sent on most of these patients. So many of these patients, especially who have stage 4 kidney disease and beyond, could have hyperphosphatemia and secondary hyperparathyroidism that we will talk about in a little bit. So we need to specifically ask for that. It happens around GFR of 25 or 30, so it's usually more stage 4 chronic kidney disease, and it can lead to hypocalcemia, and that both of them can lead to secondary hyperparathyroidism. KDOQI recommends phosphorus of 2.7 to 4.6, which is the normal for stage 3 and stage 4. Once patients get to 5 and above, usually 5.5 is the high limit of normal. Or the other way is calcium phosphorus product, which is calcium multiplied by phosphorus of less than 55. The typical diet contains between 1,200 to 2,000 milligrams of phosphorus in a typical diet. You really need about, the renal patient can only handle between 8 to 1,000, so almost half of it. So anything above that can potentially lead to hyperphosphatemia. What are the high phosphorus foods? Dairy products for the most part, colas, all of them do that. Beer, chocolate, whole grain, bran, nuts, beans, and lentils. Some of the things we encourage our patients to eat to some extent because they are healthy. The same thing for the potassium. And again, fleet enemas, as I indicated earlier, And nowadays with colonoscopy prep, it really has been almost eliminated. Most people do not use that because of the risk with chronic kidney disease. We use phosphate binder to treat hyperphosphatemia, either calcium salt, either calcium carbonate, or calcium acetate, which is commonly used as Foslow, has to be given with meal. There is calcium citrate. And that happens more as people get closer into stage 5, that hyperphosphatemia becomes a major factor. There is some concern about excessive calcium use in chronic kidney disease and dialysis patients because of the increased coronary calcification, and that adds another risk factor. So patients who are at high risk of this, we use non-calcium binders, and sevelamer is one of them, which Renagel is sevelamer hydrochloride, and Renvela is bicarb. So many of these medications are used on dialysis patients, but you may be seeing that in your office patients, so I'm bringing this up to we know what these medications are. It is a polymer that binds phosphorus in the food with the diet and then goes down with the stools, since renal excretion is minimal. Most common side effect is diarrhea and bloating. Lanthanum is another one. It's actually a rare earth metal. It's chewable and between 500 to 1,000 milligrams with each meal. We don't use aluminum hydroxide anymore. It's very effective, but there is a concern for aluminum toxicity. And there are some newer ones that contain magnesium. You have to be careful because magnesium and phosphorus are renally excreted as well. So secondary bone mineral metabolism or bone mineral disease is an important factor for chronic kidney disease before and after dialysis. So KDOQI has recommendations for PTH or parathyroid, intact parathyroid hormone levels that would be appropriate for these stages. So as GFR declines, as you can see, we accept a higher level of secondary hyperparathyroidism. So at stage 3, 35 to 70 is the normal, and you want the calcium not to exceed 10.2. Stage 4, you accept a little bit of a higher level between 70 and 100, and for stage 5 or dialysis patients, you want it between 150 to 300. We'll talk about how to manage that. So secondary hyperparathyroidism and renal osteodystrophy is an area that it's not widely talked about outside the nephrology community. So it can be caused by phosphate retention and hyperphosphatemia. Also decreased free calcium levels, and one of the main factors is decreased 125 dihydroxyvitamin D, which is calcitriol, because we know that the vitamin D gets activated in the liver and then subsequently in the kidney, so the lack of hydroxylation in the kidney will lead to decreased effect of vitamin D, and as a result, that basically will lead to activation of parathyroid hormone, which in essence will try to mobilize calcium from the bone to the blood to normalize serum calcium. And that results in osteomalacia, which is low turnover and unmineralized bone, osteitis fibrosa cystica, which is high bone turnover because of elevated parathyroid. We see that only in advanced dialysis patients. Adynamic bone disease, which is low bone turnover. We know that PTH has an osteoblastic and osteoclastic activity. So if you suppress it too much, you can end by having low bone turnover disease or adynamic bone disease. That's why we have a higher limit of accepted parathyroid hormone as kidney function declines. How do we treat it? Normalize serum phosphorus with the levels mentioned above, and then vitamin D analogs. So you see some of your patients who see some of us are being treated with calcitriol, pericalciferol, or doxycalciferol. That after you correct vitamin D. So somebody comes to you, you first check vitamin D, which nowadays we check on many patients because of the epidemic of vitamin D deficiency. You want the regular vitamin D to be above 30 before you start treating them with active vitamin D. If that is not enough, we add calcitriol or one of the other forms depending on which one they tolerate and what is covered by their insurance. Pericalciferol and doxycalciferol should have less risk and incidence of hypercalcemia, but we frequently can use any of them interchangeably. Patients who have severe secondary hyperparathyroidism, usually in the hundreds, not responding to the above, or as you start treating them, they develop hypercalcemia, can be used with a calcium mimetic, and that is cinacalcet, or the brand name for it is called Sensipar. It's the only medication in the market, and basically it increases sensitivity of calcium sensing receptors in the parathyroid, so it becomes less sensitive to the hypocalcemia, so it decreases the amount of production of PTH. In a way, it's really like medical parathyroidectomy. It comes in 30, 60, and 90 milligram. Maximum daily dose is 180. The main adverse effect is GI problems. It happens about 15 to 20% of cases. And of course, if you overdo it, they can get hypocalcemic. Lastly, we'll talk about anemia and chronic kidney disease, which is caused by decreased erythropoietin production, typically normocytic, normochromic, and happens with kidney disease as GFR declines less than 60, and especially when they get to less than 35, which is advanced stage 3, close to stage 4. Before we start treating or assume that it's anemia of chronic kidney disease, you need to rule out other causes, most commonly B12 and iron deficiency. They have to have a T saturation, iron saturation of 20% or above, and a ferritin of 100 with normal B12 and folate before we start treating them with erythropoietin stimulating agents. DOC recommends maintaining hemoglobin between 10 and 12, and we correct iron first, as I indicated, either PO iron, which is not always tolerated. If the patient has significant iron deficiency, after ruling out the cause, you can treat them with intravenous iron, either ferrous gluconate or iron sucrose, and we typically give between 500 to 1,000 in divided doses. Fairly effective and is much safer than iron dextran, which is MFAD, that is not used anymore. Some patients develop hypertension and myalgia, but the risk of anaphylaxis that we used to have with the iron dextran is almost unheard of. Just be careful not to use it when there is an acute infection or inflammation with a high ferritin, and certainly contraindicated in bacteremia because of the possibility that it does decrease chemotaxis and risk of not being able to fight the infection. The 3 agents available in the US market is Procrit, available for chronic kidney disease, Epogen, which is typically given intravenously in dialysis, and then darbepoetin, which is Aranesp, longer half-life, every 2 weeks or so. Now, there have been, over the past couple of years, some new concerns about who to treat with ESA or erythropoietin stimulating agent. And without going into a lot of details, there are these studies that I listed some references for them, the Choir studies, CREATE, TREAT, NHT. Basically, the essence is, if we try to normalize hemoglobin, there is increased risk of thrombotic events and cardiovascular mortality. So treating anemia is good. People don't feel well when they are anemic, but if we correct it above 12, there is really becomes counterproductive, and patients do worse than people with a lower level. Most patients tend to have symptoms with hemoglobin is less than 10, rarely above that. And normalizing that, one of the advantages of treating them is the regressive left ventricular hypertrophy, which is one of the causes of cardiovascular problem. It does have an impact on quality of life, cognitive function, exercise tolerance when the hemoglobin is between 10 and 12. There is a lot of debate about this, but one of the 2012 KDIGO recommends using erythropoietin stimulating agents to keep hemoglobin between 10 and 11.5. And really, if the patient has recent stroke or significant cardiovascular risk or active malignancy, either do not use or use with caution because of that increased risk. The last part here is really, when do we refer? I get that asked this a lot as well. When do we refer patients to see a nephrology and prepare for renal replacement therapy? Most people accept GFR of 30 or below as a reason for referral. Above that, there is some question. There are some studies showing actually that earlier referral decrease mortality and morbidity. One of the main things we start doing as we start seeing these patients, as they progress or as they get closer, especially when the GFR in the 20s and certainly below 20, you start talking about education regarding renal replacement therapy, dialysis modalities, and we go over the whole program. There is conventional in-center hemodialysis, which is the most commonly used in the United States. There is in-center nocturnal dialysis, where patients go and for 8 hours sleep in a dialysis center 3 times a week, primarily helpful for patients who have significant volume problems. And then there is home modalities, which is really more and more becoming talked about, and the more we educate patients, many of them choose this. And either that is peritoneal dialysis, and that's either continuous ambulatory peritoneal dialysis or continuous cycler peritoneal dialysis using an automated machine to do the dialysis at night when the patient is asleep. So it gives them a lot of freedom during the day. And there is also home hemodialysis with a special machine that the patient can do dialysis at home. And both peritoneal, the home modalities have been shown to really improve outcome, improve functional capacity of the patient, in addition to the psychological effect of more independence and so forth. At the same time, we start referring patients to transplant. When the GFR in the 20s, certainly below 20, most transplant center will accept patient for transplant evaluation and preparing for that before patients end on dialysis. Preferred is living donor if they have a living donor available. Those who do not have a living donor, after they go through a period of evaluation, they will be activated on a transplant registry for deceased donor transplant. I labeled this slide access, access, access. One of the main reasons for referral for transplant in preparing for this is preparing for the access for dialysis. Those who will end on dialysis, especially hemodialysis, their vascular access is their lifeline. There is a huge difference between patients who start dialysis with a functioning access and those who start crashing and having to have a dialysis catheter inserted. Should we start planning this when the GFR is 20 mL per minute? Most national organizations and international agree on that. Best option would be native AV fistula. Usually means a good vein and at least 6 to 12 weeks to mature. So if you're anticipating somebody needing dialysis within a few months, really you should be putting a fistula in. Synthetic grafts for those who have poor veins. Tunnel dialysis catheters are the last option. They work immediately, and sometimes we have to do that if somebody needs to start dialysis tomorrow. We don't have time to do one or the other options. The other option, people who choose to go on peritoneal dialysis will send them for an embedded PD catheter. That can be put in almost a year prior to needing it. So if you're not sure, it's very hard to predict when patients exactly will need dialysis, and sometimes they crash and they need it sooner. So it's better to be prepared, have the access, and then if they need it sooner than you expect, you're fine. There is much less risk of creating an access prematurely than having patient needing dialysis and not having a functioning access. One thing we have to mention here, as we have older population with frail people with multiple comorbidities, is some of these patients will not wish to proceed with dialysis because of their functional status and their age. And if that happens, really there need to be a discussion with these patients who are approaching dialysis, that really what do you want to do if you end on dialysis one day. Should be part of the discussion about end-of-life issues, about advanced directives, and oftentimes that gets neglected in the discussion. In addition to, do you want to be resuscitated? Do you want to be intubated? I think if we know somebody has stage 4 chronic kidney disease or beyond, that should be the discussion. So if they choose not to proceed, then we make sure we honor their wishes and we would focus as their renal disease progress towards more palliative care approach. So in a quick summary, when you see somebody with chronic kidney disease, if it's less than 3 months in time, we call that acute kidney injury. HMP, detailed, try to figure out the cause. At least do a urine analysis and ultrasound. Think about pre-renal, renal, post-renal. If they have persistent proteinuria or microscopic hematuria with an active urine sediment, make you think about glomerulonephritis and RPGN. If you see this patient in the office, this patient should not go home and come back in a few months. They should be followed in a week or two. If they have progressive renal failure or more persistent proteinuria, they should be referred or maybe admitted if the creatinine is elevated. And many of these patients will need a kidney biopsy. If it's more than 3 months, not changing quickly, that is chronic kidney disease. HMP for sure, to really know the history and try to look at the risk factors and try to narrow down the differential as we talked about early. Again, urine and a kidney ultrasound should be done on everybody. In terms of workup, if they have no proteinuria, no hematuria, all the patients have the right risk factors for nephrosclerosis, we typically recommend doing an SPEP and UPEP to make sure they don't have a monoclonal gammopathy, identify risk factors, and then manage chronic kidney disease consequences, which we just finished talking about. If they have, on the other hand, proteinuria, microscopic hematuria, then we really need to do all the serologies, ANCAs, ANA, and so forth. And many of these patients, again, will need a referral and a renal biopsy. The only exception if you have somebody who's long-standing hypertension, they had microproteinuria, over the years they have had progressive proteinuria, no active urine sediment. These patients usually do not need to be biopsied, and as we talked about earlier, they have to be on an ACE or an ARB. If there is any red flags, they should be referred, and then we frequently do a kidney biopsy if we're not sure if there is anything else